Good morning to all. Today we are going to discuss about the physiology of inhalational anesthetic agents. Inhalational anesthetic. Inhalational anesthesia refers to the delivery of the gases or the vapors to the respiratory system to produce anesthesia. The history of introduction of the various inhalational agents. This chart shows the introduction of various anesthetic agents in various time duration. The initially nitrous oxide came in the period in 1840s, then after that ether and chloroform, then after 1880s, the ethyl chloride. After that, due to various disadvantages and harmful effects of these inhalational agents, then ethylene, divinyl ether, cyclopropane, isopropyl vinyl ether, and fluoxetine, halothane, N-fluorine, desflurane, sevoflurane has come in the clinical use. Diethyl ether, first used by the William T.G. Morton in the United States of America in 1846. Chloroform was the next agent to receive attention by the James Simpson in 1847. Then soon after, it was discontinued due to this adverse effect like severe cardiovascular depression, which leads on to sudden death by ventricular fibrillation and dose-dependent hepatotoxicity. Cyclopropane was discovered in 1929 and was very popular for almost 30 years. Due to increasing use of the electronic equipments and due to this inflammable property of these inhalational agents, these were soon discontinued from the clinical use. Halothane, in 1951, it was synthesized by the British chemist Charles Walter Suckling while working at the Imperial Chemical Industries. Later in 1956, Johnstone used it clinically the first time. N-fluorine came into the clinical use since 1970. Then, as I said, then isoflurane, desflurane, then sevoflurane came for the clinical uses. A variety of other agents were investigated but discarded for various reasons, like explosive when it mixed with the oxygen. The property has the ethyl chloride, diethyl ether, divinyl ether, cyclopropane, and some other agents cause the liver necrosis and sudden death, like chloroform, and post-operative renal failure by the methoxyfluorine. Types of inhalational anesthetics, it can be liquid or gases, the volatile liquid. The examples are ether, halothane, N-fluorine, isoflurane, desflurane, and sevoflurane, whereas in the gaseous forms are the nitrous oxide and cyclopropane. Ideal inhalational anesthetic agents, it should be the physical properties, it should be stable over a range of temperature, not to be degraded by the light, does not require the presence of any preservative. It should not explosive when it combined with the oxygen, and it does not support combustion. It should be odorless or it has a pleasant smell, environmentally safe, does not react with other components, mainly the soda lime. It has a boiling point well above the room temperature. And the pharmacodynamic property of the ideal inhalational agent, it should have a predictable dose-related CNS depression, analgesic, anti-emetic, and muscle relaxation properties. Minimal respiratory depression does not cause coughing or bronchospasm. Minimal cardiovascular effects, no increase in cerebral blood flow, and therefore intracranial pressure. It should not have any epileptogenic property, does not impair renal or hepatic function. No effect on the uterine smooth muscle, does not trigger of malignant hyperpyrexia. Pharmacokinetic property. It should have a low blood gas solubility coefficient, low oil gas solubility coefficient, should not metabolize or in otherwise it should not give any active metabolites which lead on to any harmful effect of the body. and it should excrete it completely by the respiratory system or any other system without any harmful effects. What is MAC value or what is minimum alveolar concentration? The minimum alveolar concentration is the best estimate for the to scale the potency of the inhalational anesthetics. The definition of minimum alveolar concentration is the minimum alveolar concentration of any anesthetics at the equilibrium at 1 atmospheric pressure, which produces immobility in 50% of the individual or subjects exposed to a standard noxious stimulus. For humans, the standard noxious stimulus is considered as a surgical incision of the skin. MAC value 1, it refers to the equivalent of the median effective dose ED50. What is 1.3 MAC? It is the 1.3 MAC is to prevent the 95% of the subjects when exposed to a standard noxious stimulus, whereas 1 MAC is referred to the 50% of subjects. What is MAC awake? MAC, minimum alveolar concentration awake. MAC of anesthetics that would allow opening of the eyes on verbal commands during emergence from anesthesia. Usually MAC awake is 0.3 to 0.4. MAC intubation is MAC that would inhibit the movement and coughing during endotracheal intubation. Usual MAC will be 1.2 to 1.3. MAC bar. MAC bar is the anesthetic property to prevent adrenergic responses to skin incision as measured by the concentration of the catecholamine in the venous blood. MAC bar is usually 1.4 to 1.5. When different agents are compared, the ratio of MAC skin incision to MAC intubation or MAC awake is relatively constant. There are various factors which affect the MAC value. Some factors increases the MAC value, some factors decreases the MAC value, some factors does not affect the MAC value. Factors which increases the MAC value, like hyperthermia, hypernatremia, drug-induced elevation of the CNS catecholamines stores, chronic alcohol abuse and chronic opioid abuse, and increase in the ambient pressure. These factors increases the MAC value. Likewise, there are some factors decreases the MAC value, hypothermia and sometimes hyperthermia when the temperature exceeds more than 42 degrees Celsius, hyponatremia, increasing age, hypoxemia when pH less than 40, hypotension when pH MAP is less than 40 mmHg, anemia, pregnancy, CNS depressant agents like opioids, benzodiazepines, other drugs like lithium, lignocaine, magnesium, acute alcohol abuse. Few factors does not cause any change in the MAC value. Sex, weight of the patient, body surface area, type of supramaximal stimulus, duration of anesthesia, hypo or hyperkalemia, hypo or hyperthyroidism, PaCO2 when it is in the range of 15 to 95 mmHg, and PaO2 when more than 40 mmHg, when MAP is more than 40 mmHg. These are all here some common MAC values for various inhalational agents. Nitrous oxide has a MAC value of 104, which is the very least potent. When methoxychloroquine has a MAC value of 0.16, which is most potent. The other MAC values for xenon is 72, desflurane is 6.6, ethyl ether is 3.2, sevoflurane is 1.2, 1.8, enflurane is 1.6, isoflurane is 1.17, halothane has 0.75, and chloroform has 0.5. How to calculate MAC value for any substance? So let's take an example. A patient getting nitrous oxide, oxygen, and isoflurane at the rate of 2 liter nitrous oxide and 1 liter of oxygen is going to the patient when the isoflurane dilate at 1.15% concentration. So the percentage of nitrous oxide going into the patient is nitrous oxide flow by the total flow, that is 2 liter by total is 3 liter. So that is 0.67%. That is 0.67, that is 67%. MAC of nitrous oxide, let's take an example. MAC of nitrous oxide is 104, so we take a round value of 100. So 67 by 100 is 0.67. For isoflurane, the MAC value of isoflurane is 1.15 divided by 1.15. We kept a dial at 1.15. So MAC value is 1.15 divided by kept a dial at 1.15. So that gives a value of 1. So the total MAC is MAC of nitrous oxide, that is 0.67 plus MAC of isoflurane is 1. So 1 plus 1.67 is 1.67. Various property of the inhalational agents: vapor pressure, boiling point, partial pressure, and concentration. Vapor pressure. If volatile liquids reside in a closed container, molecules of substances will equilibrate between the liquid and gas. At equilibrium, molecules of gas exert pressure over the wall of the container is vapor pressure. Boiling point of the liquid is the temperature at which its vapor pressure exceeds the atmospheric pressure. The gasoline pressure, vapor pressure is 669. Huge amount of gas molecule equilibrate with the liquid state. So fresh gas flow will take high amount of desflurane molecules. Here showing the various boiling point and the vapor pressure for the halogen, isoflurane, desflurane, sevoflurane, anesthetic agents. Here the boiling point is 50 for halogen, whereas vapor pressure is 243. Isoflurane is 48 and vapor pressure is 250. Desflurane is 22.8, whereas vapor pressure is 664. Sevoflurane is 58 boiling point and the vapor pressure is 160. Then partial pressure. Partial pressure assumes the importance because the gas equilibrate based on the partial pressures, not concentrations. Dalton law of partial pressure is the partial pressure of the total gas is equal to the partial pressure of the mixture of gases. Theories of anesthetic agents. There are various theories to elaborate the mechanism of action of the anesthetic inhalational anesthetic agents. The lipid solubility described by the Overton and Mayer, an alteration to the lipid bilayers, that is lipid perturbation, lipid phase transition, and lipid protein interactions. And alteration to protein function, luciferase inhibitions. The best correlation with the anesthetic potency was noted to be the olive oil and gas partition coefficient by the Overton and Mayer in 1899 to 1901. Mayer and Overton discovered the striking correlation between the physical properties of general anesthetic molecules and their potency. The greater is the lipid solubility of the compound in olive oil, the greater is its anesthetic potency. So that is why the lesser the MAC, the greater the potency. Halogen has the MAC of slightly less than 1, while the nitrous oxide has the MAC of around 104. So halogen is much more potent than nitrous oxide. And this because the log of the MAC is plotted on the y-axis. The halogen has a value of 0.01 and the nitrous oxide has a value of 1. Here the graph shows the logarithmic value of the MAC value of these inhalational agents. There are some exceptions to this Mayer-Overton rule. N-chlorine and hexafluorine are structural isomers and have similar oil-gas partitions coefficients. However, the MAC for isofluorine is only 70% of the N-chlorine. Thus, it would appear that there are some other factors which influence the potency. This includes convulsion property, the cutoff effects, that is beyond which anesthetic potential sharply decreases, specific receptors, lipid perturbations. This is better explained by the critical volume hypothesis binds with the lipophilic site and pressure reversal effect. Hydrophobic anesthetic molecules accumulate inside the hydrophobic or lipophilic regions of the neuronal lipid membrane, causing its distortion. Here, it causing distortion and expansion. Accumulation of this anesthetic causes volume of the hydrophobic region to expand beyond some critical volume sufficient to reversibly alter the function of the membrane ion channels, thus providing anesthetic effects. This theory was supported by the experimental fact that increases in atmospheric pressure reverses anesthetic pressure. That explains the pressure reversal effect. The protein-based theory of anesthesia is demonstrated that dental anesthetics may also interact with the hydrophobic protein sites of certain proteins like GABA receptor, diastole receptor, glutamate receptor, neuronal nicotinic. The other actions are anesthetics induced ablation of the movement in response to pain is primarily mediated by the spinal cord. Anesthetic induced amnesia is mediated by the higher brain structures hippocampus. Anesthetic induced sedation mediated by hypothalamus. Uptake and distribution of inhalational agents. Transfer, transfer from inspired air to the alveoli, from alveoli to arterial blood, from arterial blood to tissues. The factors which affect the transferring from inspired air to the alveoli, inspired gas concentration, alveolar ventilation, and the characteristic of anesthetic circuits. The factors which affects the transfer from alveoli to blood is blood gas partition coefficient, cardiac output, alveoli to venous pressure difference. Factors which affects the arterial blood transfer to tissues, that is tissue blood partition coefficient, tissue blood flow, and arterial to tissue pressure differences. This picture shows the whole transportation of the inhalation agents from the inspired gas mixture to the blood and to the tissues and like vein and various other tissues and return from the tissues through the venous blood to the alveoli and exhalation. So inspired gas goes to the alveoli and thereby to the uh, arterial blood and thereby it goes to the brain and various tissues. Transfer of inspired air from the anesthesia machine to the alveoli. The fresh gas flow is determined by the vaporizer and the flow meter settings, whereas fractional fraction of inspired gas concentration is determined by the fresh gas flow, breathing circuit volume, and circuit absorption, whereas fraction of alveolar gas concentration is determined by the uptake of the anesthetic agents and ventilation and the concentration and second gas effects. fraction of arterial gas concentration is affected by ventilation perfusion mismatch. Factors affects inside gas concentration, that is FI, is mainly by fresh gas flow, breathing circuit volume, and breathing circuit absorption of the inhalation agents. Concentration in the circuit will rise according to the first order kinetics. So Fi is equal to fraction of fresh gas flow into 1 minus e to the power of minus t by tau. Characteristics of first order kinetics is to reach 95% maximum when it takes the 3-time constant. According to the Dalton's law of partial pressure, the tension of the individual partial pressure of the individual gas is in the inspired air is equal to fraction of inspired gas into atmospheric pressure. The greater the inspired pressure, the greater the approach. So of FA to FI, that is the concentration effect. This is only significant where Fi is very high, as is the case for the nitrous oxide. When another gas is used in the presence of such agent, then there is an increased uptake of the second gas. This is called the second gas effect. Alveolar ventilation. Each inspiration delivers some anesthetic to the lung, and if unopposed by the uptake into the blood, normal ventilation would increase FA by FI to 95 to 98% in 2 minutes. This rate of rise is dependent upon the minute ventilation and the FRC. The greater the FRC, the slower the rise in FA. Hyperventilation will decrease cerebral blood flow, and this tends to the offset that increased rise of FA by FI. Factors affect the alveolar concentration of blood uptake, cardiac output, blood gas coefficient, arterial to venous pressure difference, and ventilation. Blood gas coefficient. The solubility of the gas in the liquid is given by its Austal solubility coefficient. That is the blood gas coefficient. This represents the ratio of the concentration of anesthetic agent in blood to the concentration in the gas phase. Lower the blood gas coefficient are seen with hemodilution, obesity, hypoalbuminemia, and starvation. Higher coefficients are seen in adults versus children, hypothermia, and postprandial conditions. This slide shows various blood gas coefficients at room temperature. Methoxyfluorine has 15, which has the slowest induction and recovery, whereas Alkane has 2.4 and xenon has 0.14, which has the earliest induction and recovery. But xenon is under invention. Nitrous oxide has 0.47, desflurane has 0.42, sevoflurane has 0.69, isoflurane has 1.4, influrane has 1.8, arthan has 2.4. So among these, sevoflurane has a 0.69, which is in use, and desflurane has 0.42. We use desflurane due to its irritable property, so we don't use it for the induction anesthesia. And sevoflurane does not cause any irritability, so we use sevoflurane, which has a 0.69 blood gas coefficient, so we use sevoflurane for an induction anesthesia. Cardiac output, which affects the alveolar concentration. Effective pulmonary blood flow determines the rate at which the agent passes from the blood to the gas to the blood. An increase in flow will slow the initial portion of the arterial tension time curve by delaying approach of FA to FI. A low cardiac output state conversely will speed the rise of FA by FI. These effects are greater for highly soluble agents. Tissue uptake of anesthetics. The tissue blood partition coefficient, tissue blood flow, and the tissue anesthetic concentration. These 3 points are the factors which affect the tissue uptake of anesthetics from the blood, arterial blood. The rate of rise into the tissue of anesthetic inhalation agents. Concentration is proportional to tissue, blood flow, and inversely proportional to the tissue capacity. The more the flow will cause the more concentration of anesthetic agent in that particular tissue. Whereas the more the tissue capacity, more the volume, more the mass of the tissue will lead on to the decrease in tissue anesthetic concentration. We take tissue as a fat as a tissue. So fat blood coefficient at room temperature is methoxyfluorine has 61, where halogen has 62, nitrous oxide has 2.3, desfluorine is 30, and sevofluorine is 55, isofluorine is 52, N-fluorine is 36. Blood flow, tissue blood flow. The higher the blood flow to the region, so faster the delivery of the anesthetic agent and more rapid the equilibration and more in the anesthetic concentration. The total amount of gas dissolved will, however, depend upon the tissue volume also. So, and agent of solubility and the agent solubility in the tissue. The blood tissue have been divided into according to their level of perfusion and tissue blood flow. Vessel rich group, that is brain, heart, kidney, and liver. The muscle group are muscle and skin. The fat group are large capacity and minimal blood flow. And the vessel poor group are bone and cartilages. In this chart showing the various tissue groups, that is the vessel rich group, muscle group, fat, and the vessel poor group. Vessel rich group accounts for 10% of the total body mass, whereas the muscle represents the 50% of the total body mass. Fat represents 20% of the total body mass, and vessel poor group are representing the 20% of the total body mass. So vessel rich group receives the 75% of the cardiac output, whereas muscle gets 19%, fat gets 6%, and vessel poor gets 0 to 1% of the cardiac output. When we talk about in vivo perfusion, vessel rich group gets 75 ml per minute per 100 gram, whereas muscle gets 3, fat gets 3, vessel poor groups gets 0 to 1 ml per minute per 100 gram of body mass. This pictograph represents the earliest anesthetic concentration in vessel-rich group like lung, blood, brain, heart. It reaches the higher concentration within few minutes of induction, whereas fat, muscle getting steady state induction and fat getting very slower induction when compared with the vessel-rich group. Other factors affecting uptake and distribution. Concentration and second gas effects. Increasing the inspired gas concentration not only increases the alveolar concentration, but also increases the rate of rise of volatile anesthetic agents in the alveoli. Example, during the inhalation of 75% nitrous oxide, initially as much as 1 liter per minute may diffuse into the bloodstream across the lung. This effectively draws more gases into the lung from the anesthetic circuit, thereby increasing the effective mean ventilation. This effect is also important when there is using of second gas like inhalation agents like argon, sevofluorine, desfluorine in the infect gas mixture. The removal of a large volume of nitrous oxide from the alveolar air increases the delivery of the second gas, effectively increasing its delivery to the alveoli and increasing its diffusion into arterial blood. This is the second gas effect. What is diffusion hypoxia? It is almost a reversal form of second gas effect. It was first described by the Fink in 1955. This is reverse of the above effect, second gas effect. The elimination of the poorly soluble gas such as nitrous oxide from the alveoli may proceed at as greater rate as its uptake, thereby adding as much as 1 liter per minute to the alveolar gas. This gas effectively dilutes alveolar air and available oxygen so that when room air is inspired, hypoxia may result. This is usually only mild and rarely clinically significant. Elimination of inhalational anesthetics. Volatile anesthetics are eliminated in the terminal phase via the lungs. The low blood gas coefficient is therefore necessary for the quick removal of the anesthetics. When the oil water coefficient is high, there will be little anesthetics in the blood, so elimination will be slow, giving a prolonged hangover effect. The factors affecting elimination are the biotransformation, like metabolized by cytochrome P450, transcutaneous and visceral loss, which is very insignificant, and exhalation, the most important one. Factors speeding the recovery that is identical to those present during induction: increased ventilation, elimination of the rebreathing, high fresh gas flow, anesthetic washout from the circuit volume, decreased solubility and uptake, high cerebral blood flow, shorter duration of exposure. Effect on different systems. In central nervous system, volatile anesthetics. Volatile anesthetics suppresses cerebral metabolism in a dose-related manner. Also possesses intrinsic cerebral vasodilatory activity as a result of direct effects on vascular smooth muscle. Order of vasodilating potency is approximately halogen is more than fluorine, then desflurane is equivalent to isoflurane. Isoflurane is more than sevoflurane. It also increases the intracranial tension. Influrane increases more when compared with halogen sevoflurane, which increases more when compared with isoflurane and desflurane. In cardiovascular system, all agents reduces systemic vascular tension, also decreases the cardiac output. Cardiac output is best maintained by isoflurane, so it is the best agent of choice for the cardiac patients. Vasodilatation is seen easily done to hypotension. In renal system, nephrotoxicity because of fluoride content. Methoxyflurane is the most nephrotoxic due to the highest fluoride content, 50 to 70 maximum. Sevoflurane is 30 to 50, so second most nephrotoxic agents. Enflurane, isoflurane is 4 to 8, halogen, and desflurane. Desflurane has the nil fluoride content, so very least nephrotoxic agents. In the respiratory system, bronchial smooth muscles, it causes bronchodilator, maximum in non-asthmatic by sevoflurane. Although halogen produces more bronchodilation in asthmatic, but it's still not preferred due to its increased chances of arrhythmias with big beta agonist. Pulmonary vascular resistance, it causes pulmonary vasodilators except nitrous oxide. Mucociliary function, it decreases the mucociliary function. In respiration, decreases tidal volume, but increases its frequency, that is, increases its rate. Sequence of respiratory depression is more with enflurane than desflurane, than isoflurane, than sevoflurane, than isoflurane. Muscular system, centrally acting muscle relaxants reduces requirement of muscle relaxants by 30%. Desflurane has the more centrally acting muscle relaxant, more action on more action than sevoflurane, than isoflurane, than halogen. Effect on liver, it causes hepatotoxic, mainly halogen, chloroform methoxyflurane. Effect on uterus, all the inhalational anesthetic agents are different relaxants. The ideal inhalational anesthetic should have the following properties like rapid and pleasant induction and emergence from anesthesia, rapid and easily identified changes in the depth of anesthesia, adequate relaxation of skeletal muscles, a wide margin of safety, the absence of toxic or other adverse effects at normal doses, high degree of specificity of action, technically easy to administer, and it should be useful for all age groups. Then we will talk about one by one. First, nitrous oxide. It's a colorless gas without appreciable odor or taste. First synthesized by Priestley in 1772 and first used in anesthetic practice by Cotton and Wells in 1834. It marketed in steel cylinders as a liquid under pressure in equilibrium with the gas phase at the normal room temperature. The gas is neither flammable nor explosive but will support combustion of flammable agents. Chemical preparation. Prepared commercially by heating ammonium nitrate between 245 to 270 degrees Celsius. Contamination with the higher oxides of nitrogen, nitrous dioxide, or nitric oxide may lead to laryngospaasm, cyanosis due to methemoglobinemia, chemical pneumonitis, and respiratory failure. Partition blood gas partition coefficient 0.47, critical temperature is 36.5 degrees Celsius, boiling temperature minus 88. It is potent analgesic agent but a weak anesthetic agent. Rate of uptake after inhalation of 80% of nitrous oxide and 20% of gas oxygen mixture at 1 minute. 1000 ml per minute at 1 minute it is 1000 ml per minute. At 5 minutes it's 500 ml per minute. At 90 minutes it's 100 ml per minute. The time taken to reach 90% arterial saturation is just about 20 minutes. This large uptake of gas and rapid effects on the emergence results in the concentration effect, results by concentration effect on the second gas effect. The main value of the nitrous oxide in the anesthesia is used as an adjuvant to the inhalational agents. Mainly, it is used with the 70-30 ratio. The action on central nervous system causes the depression and produces the analgesia. Also increases cerebral blood flow and thereby increases the intracranial pressure. And that these remain responsive to changes in the PaCO2 and are less affected than with the volatile agents. Cardiovascular effects of nitrous oxide alone is very small. Although it is small, it has a direct myocardial depressant effect on cardiac output, contractility, and heart rate that and reduce the total peripheral resistance. Therefore, no change in blood reduces the heart rate and thereby increases the total peripheral resistance. So this lead on to no change in blood pressure or small change. As the nitrous oxide increases the arrhythmogenic potential of all agents, less volatile agents required, so therefore less cardiorespiratory depression. The respiratory system is very insignificant effect. No change in the respiratory response to carbon dioxide. There is a decrease in the hypoxic drive when 50% nitrous oxide is inspired. There is no change in bronchomotor flow. Metabolism, it is eliminated through the lung by 95% and 5% through the skin. Toxicity, it antagonizes the B12 metabolism, that is cobalt oxidation. So it thereby leading to inhibition of the myelin formation. That is methionine synthesis is decreased, thereby decrease the myelin formation. And thymidylate synthesis, thereby decrease the DNA formation. Also, the toxicity of the nitrous oxide is marrow aplasia, megaloblastic anemia, iatrocytosis. Also, it affects the chemotaxis and mobility of polymorphs, lead on to infection. Possible teratogenicity, spontaneous abortion. This is due to the decreased DNA formation and myelin formation and destructive to ozone. Either the older drug, which is produced in 1540 and came as an inhalational anesthetic agent, it was used till 1840. It is easy to manufacture and it is produced by the heating concentrated sulfuric acid with ethanol. It is considered one of the safest inhalational drugs to give because the respiratory depression precedes cardiovascular depression. However, giving it is complicated by its slow onset and offset and airway irritation. Its flammable properties also a problem. Physical properties: it is clear, colorless liquid. It does not contain preservatives or react with other compounds. It has sweet smell. Pharmacodynamic properties: in CVS, it has a direct negative inotropic effect. Cardiac output, heart rate, and blood pressure are maintained. It causes the dilatation of the coronary arteries. In respiratory effect, it acts as a respiratory stimulant, increasing respiratory rate. Later, after induction, it acts as a respiratory depressant. In CNS, it has a mild analgesic property. It causes cerebral vasodilation, thereby increasing cerebral blood flow, which lead on to increased intracranial pressure. Also, it may cause convulsions. It increases the secretion, thereby leading to increased salivation and lacrimation, and lead on to increase incidence of postoperative nausea and vomiting. It reduces the gastric motility, lead on to post-PONV. Halogen, which is clear colorless liquid degraded by light, contains 0.1% thymol, which prevents the decomposition on exposure to light. It is non-flammable. Boiling point is 50.2. Characteristic is sweet smell odor. MAC is 0.75. Blood gas solubility is 2.3. Oil gas solubility coefficient is 234. CVS, the most important effect of halogen is arrhythmogenic property, dose-dependent increase in cardiac contractility, heart rate, and systemic vascular resistance. It sensitizes the myocardium to circulating catecholamines that lead to the arrhythmogenic property of halogen in cardiovascular system. Halogen causes a dose-dependent reduction in tidal volume and minute volume. Also, it reduces the bronchial secretion. The main property is bronchodilation in the respiratory system. CNS, it has no analgesic properties. It causes cerebral vasodilation and therefore increases the intracranial pressure. One of its major disadvantages is that repeated exposure can cause autoimmune hepatitis. This is caused by halogen metabolites binding to the hepatic proteins on the hepatocyte cell membrane and modifying their structure. The most common halogen-induced side effects is hepatic necrosis and failure. Isoflurane. The physical properties of isoflurane is clear, colorless liquid, not degraded by light, does not contain preservatives, not inflammable. Boiling point is 48.5 degrees Celsius. It has a pungent odor. So, due to its pungent odor and it is irritant to the respiratory system, we don't use isoflurane for the induction of anesthesia. MAC is 1.15, blood gas solubility is 1.4, oil gas solubility coefficient is 91, which is 0.2% in metabolized in the liver. Pharmacodynamic property: isoflurane is a mild negative inotropic agent. Dose-dependent fall in mean arterial pressure. It causes reflex tachycardia and it does not sensitize the myocardium to circulating catecholamines. It causes coronary vasodilation. On our respiratory system, dose-dependent decrease in tidal volume and minute ventilation, increase in respiratory rate. It causes bronchodilation. In CNS, no analgesic property, lower concentration of isoflurane does not increase cerebral blood flow and thereby no increase in intracranial pressure. It's not an epileptogenic agent. It reduces muscle tone in the uterus. Sevoflurane, physical property is clear, colorless liquid, not degraded by light, does not contain preservative, not soluble, does not react with metals, reacts with soda lime to form compound A. Again, compound A is the agent which lead on to the nephrotoxicity. It's not flammable. Boiling point is 58.5 degrees Celsius. Pharmacokinetic properties. It has a MAC value of 2. Blood gas solubility coefficient is zero point 0.6. Oil gas solubility coefficient is 53. Only 3 to 5% gets metabolized in liver. Pharmacodynamic property, sevoflurane has a dose-dependent fall in cardiac output and systemic vascular resistance and mean arterial pressure. It does not reduce heart rate. It does not sensitize the myocardium to the circulating categories. On respiratory system, it causes less depression than other drugs. It causes bronchodilation, and it's not a irritant. In CNS, it has no analgesic properties. It has similar action on the cerebral circulation. It reduces muscle tone in the pregnant fetus. Desflurane is the most recent commercially available inhalational agent. Its main advantage is that it has the most rapid onset and offset of action of all the available drugs. Despite its ideal property, it has not gained widespread use. This is mainly because of its bronchial irritation, but also because it requires a specialized vaporizer, which is more costly to maintain. The physical properties: it's a clear, colorless liquid, can be degraded by light, does not contain preservatives, does not react with other compounds, it's non-explosive but flammable at concentration more than 17%. It has a boiling point of 23.5 degrees Celsius. Due to its low boiling point and therefore high saturated vapor pressure, it requires a specialized vaporizer as a conventional vaporizer would be inaccurate. The specialized vaporizer heats the desflurane and keeps it under pressure. It is then injected into the incoming fresh gas, which is also heated. Pharmacokinetic property of the desflurane, the MAC value is 6.6 to 6.6. Blood gas solubility coefficient is 0.2, so which is very lowest, which leads to rapid onset and offset. Oil gas solubility coefficient is 19. Only 0.02% gets metabolized in the liver. Due to its poor lipid solubility, very little is also metabolized. Desflurane is one of the least potent inhalational drugs. It has also quite a high age-dependent fluctuation in its potency. Pharmacokinetic effects: it causes a dose-dependent decrease in myocardial contractility and systemic vascular resistance, and thereby mean arterial blood pressure. It increases heart rate but does not sensitize the myocardium to circulating catecholamines. On the respiratory system, it causes a dose-dependent decrease in tidal volume and minute ventilation. It can increase the respiratory rate. In higher concentration, it is a potent irritant, causes a respiratory secretion. In CNS effect, it has no analgesic property. Below 0.8 MAC, it does not cause an increase in intracranial pressure. It is not an epileptogenic. Also, it does not decrease renal glucose.